Good evening. I'm Dr. Donald O'Malley, and thank you for joining us this evening for our event, Joint Explorations. Tonight we'll be talking about minimally invasive approaches to relieve shoulder pain. At the conclusion of the presentation tonight, we'll address questions from the audience. Please submit any questions through the Zoom meeting chat, and we'll address these at the end of our session. So a little bit about my background. I'm in my 27th year here in Falmouth, so that makes me the most senior orthopedic surgeons. Some say the most oldest. I like to think the most experienced. At Falmouth Hospital, I've been previously the past chief of surgical services of all the surgical services, and I've been a member of the credentials committee. At Cape Cod Healthcare, I've been on the board of trustees for 7 years and the Cape Cod Preferred Physicians for 6 years. I went to the military medical school in Bethesda, Maryland, and I spent a career after that in the Navy, finishing up as an orthopedic consultant at the U.S. Coast Guard Academy. I am the medical director of the Cape Cod Baseball League, and I'm the team physician for the Falmouth Commodores. I was the medical director of the Falmouth Road Race for a number of years, and I gave it up in 2013 to actually run the race. What an experience. I provided medical support at the Falmouth Road Race finish line tent for 24 years. I missed last year because I was in Ireland giving a lecture, and I missed 2013 because I ran it. I've done a variety of different events, including David's Old Silver Swim for ALS, and the Main Street Mile, Flag Day, Falmouth in the Fall Road Race, and Cape Cod Marathon and Half Marathon. Not a road race goes by that I don't get involved in. We're talking about shoulder pain tonight, and shoulder pain has many diagnoses. Everybody comes in my office and says, "Hey doc, I think I tore my rotator cuff." Well, there's a whole bunch of different things other than the rotator cuff that can be going on. And here's some examples of it: impingement, instability, calcific tendonitis. We'll talk about all of these individually as the lecture goes on. Well, first things first, shoulder pain. We always start conservative. You start with conservative treatment. That would be rest and activity modification, some ice therapy to the shoulder, some non-steroidal anti-inflammatory drugs, that's your Motrin, Advil, Aleve. With Tylenol, they're cleared by 2 separate mechanisms, so it's okay to take both. Some physical therapy, either patient-directed physical therapy, where you're doing the physical therapy yourself after instructions in my office, or formal physical therapy. We use Voltaren gel. It's a non-steroidal anti-inflammatory that's been deregulated by the FDA and is sold over the counter now, and you rub it into your shoulder. We may use steroids, oral steroids that you take by mouth, or an injection into the joint. Well, we're talking about minimally invasive surgery. We should start with arthroscopy, the shoulder scope. We do this through 3 small half-inch incisions. It's same-day surgery. It's good for impingement, instability, calcific tendonitis, and DJD of the AC joint. You see here I have a patient set up in the beach chair position, and I've outlined the anatomy of the shoulder, and you see the 3 tiny small portals where they go. 1 in back, 1 on the side, 1 in front. No bigger than the tip of your small nail. Impingement. Impingement is a compression of the bursa under the shoulder. You see the shoulder coming out like this, is catching the bursa underneath and pinching the bursa. It'll cause bursal swelling, and the bursa pressing down on the rotator cuff will then cause some tendonitis. It's usually also caused by spurs on the roof bone, the acromion, over the shoulder where the rotator cuff is. So if you got some spurs, they're going to press down into the bursa and cause the bursal swelling and cause impingement. Most of the time it's related to overuse. This time of year, raking leaves for 8 hours on a Saturday, painting a kitchen ceiling, something you're not usually used to doing, and you push your arm to do this. Instability, you can see the arrow here, that's on the labrum. The labrum is a small little cartilage that goes around the socket to hold the ball in the center. So the labrum can get torn off, and in that case you get instability, the shoulder sliding in and out of the joint. And what we do, as you see in the picture, we put 3 small tacks in and we just tack the labrum right back down. Calcific deposits, you get the deposit of calcium within either the bursa or the tendon of the rotator cuff. These calcific tendinitises are very painful. The calcium crystal itself is very irritable to the lining of the joint, even worse so than gouty crystals. And so they can cause extreme nagging pain, the type of pain that keeps you up all night. The acromioclavicular joint is the junction between the clavicle and the acromion. And you see here a normal acromion joint and an arthritic AC joint. And we take care of that at the time of surgery with a high-speed burr, and we just remove the end of the joint, as illustrated on this slide. Adhesive capsulitis. The layman will call it frozen shoulder. It's when something invades the capsule and causes fibrosis and thickening of the capsule with an acute inflammatory reaction of the capsule. We usually divide this into 3 phases. The layman's term, the freezing phase, the frozen phase, and the thawing phase. And the freezing phase is the active one where things are attacking the joint capsule. Very, very painful. The frozen stage is they finished their attack, now they're just resting there, and the capsule's actually thickened. And so you lose your range of motion, and it's non-painful at that stage. And the thawing phase is when the elastic fibers come back in to the capsule and you start being able to stretch that capsule out again. You don't notice it right away. This whole thing takes about 2 years. But the good news is that 98% of patients get full range of motion after having a bout of this adhesive capsulitis or frozen shoulder. Well, arthroscopic rotator cuff repair. Arthroscopic rotator cuff repair is where we go in through those 3 little tiny incisions and we take a torn cuff like you see here on the left of the slide, and we actually repair the cuff back down. I brought a little demonstration model here tonight to show you what we do at the time of rotator cuff repair. And this would be the top of the shoulder right here. And this will be our rotator cuff tear right here. And so we take a little anchor at the time of surgery. This is an absorbable anchor, and we just kind of make a little punch hole, and we just kind of screw the anchor in here. So now my anchor is set in bone. I release my sutures. And when I pull this up, now I have these sutures embedded into bone, into the anchor, and the anchor is very strong into the bone. It's not going anywhere. I then have a fancy instrument where I can take one of these sutures load it onto this device right here. So we just kind of load it on. And then I come under the cuff here like this, and I just squeeze the trigger, and it delivers the suture right through the rotator cuff. I just pull it back like this, and I've got one suture done. I then take another suture, I reload this suture, I pass it into the joint, I pass it through the joint, and bring this one up. Now, for clarity's sake, I have 3 sets of sutures here that I can pass through, but to make it clearer, I'll show you with just one suture. And then what we do is we do arthroscopic tying techniques where we tie the knot outside the shoulder and we slide it down with a knot pusher. We have a knot pusher that just slides it right down there, and then we pull it tight, and there's the rotator cuff tear back down. We put a security stitch in, an extra throw here, and there's your rotator cuff repair. So we'll repeat it with multiple sutures here, repairing the cuff back down to the bone, which then allows the cuff to heal into the bone in the process over 6 weeks. So it grows these fibers into the bone called Sharpie fibers, which is the same way the rest of the rotator cuff is attached. So that is a rotator cuff repair. And when we get all done, it pretty much with all the sutures, it looks like the screenshot there. Well, the Regeniten patch. The Regeniten patch is something real new. It's a bioinductive implant. It's actually this type 1 collagen. It acts as a scaffolding for the regrowth of the rotator cuff. So if you have big tears or unstable tears, or especially I use it for re-tears, and you bring everything down, you take this and you put it over the top for added security. What happens is the rotator cuff will grow into this bioinductive implant and use it as a scaffolding to get stronger repair. In fact, re-tear rate is 3 times lower when you use a Regeniten patch than when you don't use it. You get better tendon integrity, and the patch is reabsorbed in 6 months. So you've got the virgin rotator cuff tissue has grown into it and repaired itself, so you don't need it anymore, so it goes away. So here's a close-up. It's inserted again through one little tiny portal on the side of the shoulder, and you see the grasper there positioning it, and then if you look real closely around the edges, you'll see little staples all around there. Those are bioabsorbable staples that we put into the patch to hold it onto the rotator cuff. So this is new, and it's done for re-tears of the rotator cuff. Well, what about balloon arthroplasty? This is something new for massive tears of the rotator cuff. We didn't have much options in younger people with massive tears of the rotator cuff until this came along. This is new technology, and it pushes the humeral head down. So as you see in that picture there, the tear of the rotator cuff, when the rotator cuff tears away, there's nothing to stop the humeral head from going up until it hits that bone on top, the roof bone, the acromion bone, and then starts grinding in bone on bone. That's very painful. So what if we put something in there to space it out? So this is where the balloon comes into play right here. What we do is, through a small little portal, we insert the balloon right there. There's the device. We insert the balloon into the shoulder, and then we blow the balloon up with normal saline, and it pushes the shoulder down. It creates it's a spacer between the roof bone and the shoulder bone right here. So this is done through the little portal right on the side. So it's an instrument like this that goes in through the little portal right on the side here like this and deploys the balloon into the shoulder. And then once the balloon's in the shoulder, we'll take and we'll inflate the balloon with normal saline, and that inflation of 20 cc's of normal saline is what expands the balloon and pushes the shoulder down so that the center of rotation is now lined up with the center of rotation. This is critically important for shoulder dynamics, for shoulder motion, that the center of rotation is lined up. So this is the balloon, and it lasts for about 1 to 2 years in the shoulder, and it dissolves. But by that time, the muscles and everything have adjusted to their new position, that it stays in that position there. So that's for massive, irreparable rotator cuff tears. They're too big for using these other techniques I've shown you, and you're too young for a reverse total shoulder. So there you see it being inflated under the shoulder, pushing the shoulder down. And the biggest supporter of this, who's had it done, is Barbara Corcoran from the Shark Tank there. And she goes all around the country supporting this balloon arthroplasty. Well, I mentioned it a few times tonight. What about reverse total shoulder? Wait, this is a lecture on minimally invasive surgery. But reverse total shoulder can be minimally invasive. We surgeons define minimally invasive as any incision less than 10 centimeters. So if you do it through a 9 centimeter incision, we consider that minimally invasive. We have to have special tools to do it through a 9 centimeter incision. We do minimally invasive total knees, we do minimally invasive hips, and we do minimally invasive shoulders. So the reverse total shoulder is the last step of the game. It's when everything's failed, the humerus is high riding, it's done in older people. I use a novel approach. I found an article from 1959 by this fellow named Mackenzie about a superior lateral approach to the shoulder, which utilizes the incision at the top of the shoulder rather than the traditional one in the delta pectoral area right in front. I remove a part of the deltoid on the front. It's a quick surgery, 1 hour and 15 minutes to 1 hour and a half tops. And we're doing it as same-day surgery now. People go home after a total shoulder replacement the same day. So we have the nurses visit them that night. Myself or my physician assistant will give them a call that night to see how they're doing. So the reverse shoulder, there you see the incision, a 9 centimeter incision at the top of the shoulder. And what we're going to do is we're going to insert, let me move some of this out of my way. We're going to insert these components right here. So people say, well, why is it called the reverse? Well, in the middle, you'll see a picture of the total shoulder replacement. On a reverse shoulder, we call this the ball and this the socket. We cut the ball off and we put the socket on this side. We take the ball and we put it on the socket side of the joint. So we reverse the positions of the components. So in a reverse shoulder, the socket side is attached to a stem that goes down the arm for stability, and the glenoid side, or the ball side, is secured with 5 different screws that go into the bone of the shoulder and anchors this all down. And so the beauty of it is, I said you have a high riding humerus. I can bring the humerus down now and marry it to the ball and have the center of rotation lined up back with the center of rotation. Remember, I said that's the secret for shoulder dynamic mobility. So now you can bring your arm up overhead, bring your arm across, bring your arm to your back. This is the reverse shoulder. We usually do this on people older than 60 years old, and it has 30-year survival rate in the European studies. It's only been approved in this country since 2004 by the Food and Drug Administration, so we don't have a lot of long-term data on it. But that we do through a minimally invasive incision. So, to sum up things, minimally invasive shoulder surgery. What's the advantages and disadvantages? The advantage over open surgery is there's less tissue damage. You're doing this through small little incisions, and you're doing it in planes that don't have to cut through muscles or detach muscles. And so the recovery time is going to be a lot quicker, and there's a reduced risk of complications if you do it through a smaller incision. This all impacts on the patient experience and their perception of the shoulder surgery. The disadvantages is there's a steep learning curve. These things aren't learned overnight. You have to continue to practice these skills in the out setting and going to laboratories and practicing. And the most difficult part is knowing the limits of the components. You have to respect the components, and not everybody is a candidate for a reverse, not everybody is a candidate for a balloon. So with that, I thank you, and I'm going to take some questions now. The first question, good one, what is the recovery period for a rotator cuff repair? So I divide the recovery period for rotator cuff repairs into two segments. The first 6 weeks after rotator cuff repair, we want you taking your arm out of the sling at the first 2 weeks and doing pendulum exercises, hanging your arm by your side and just moving like a pendulum. We give you those exercises in the office. When you come back in at 2 weeks, we take the 3 little stitches out, we let you start driving, we let you stay out of the sling after 2 weeks, and you continue doing the pendulum exercises for the next 4 weeks. Then you come back and see us again, we check your range of motion, and we graduate you into the second 6-week phase, the strengthening phase. The strengthening phase is where you have an elastic band tied on the door and you're pulling an elastic band or a TheraBand. Those are progressive resistive exercises. You might be laying on your side with some weight in your arm, lifting a 2-pound weight. Those are the different exercises. So at the end of that, let's say 6 weeks of range of motion, 6 weeks of strengthening, we'll be at 12 weeks. You're about 80% there. The rest of the year is called the maturation phase. The maturation phase is when all that collagen that healed itself in a mishmash of ways starts aligning itself in the direction of the forces. That's called Wolff's Law. That takes almost a whole year to do. But at 80% at 3 months, you're pretty much doing everything you want to do. We have some restrictions for, heavy lifting, nothing greater than 25 pounds. Prolonged activity, we don't want you raking for 8 hours. We want you supervising the raking for 8 hours and that type of thing. So it's a very straightforward recovery phase. How long does an arthroscopic operation for impingement typically take? Will I have to do PT following surgery? So impingement, remember, we're going in there and we're suspicious that there are spurs pressing down on the bursa and the rotator cuff. And we're going in there with that burr to get rid of the spurs. So we go in there and we get rid of the spurs. It takes about 20 to 25 minutes to do that procedure. But that's just part of the procedure because we go into the joint, we look at the labrum, we look at the articular surface, we look at all the tendons on the inside of the joint, what I call a 12-step maneuver where I go all around the inside of the joint. Then we come above the joint where we'll get rid of those spurs, we'll look at the rotator cuff from above, we'll look at the bursa, and we'll look at the clavicle as well as the AC joint. So the whole thing will probably take me about 45 minutes to do. And then will you have to do PT following surgery after impingement? Generally not. Generally, we see you at 2 weeks, and we've given you the pendulum exercises to go home with, and we'll check your range of motion at 2 weeks and see how you're doing, the general comfort range you're in, and we'll guide our therapy from there. We may continue doing home exercise therapy that's patient-directed by yourself, and then see you back in another 4 weeks. But generally, you do not have to do physical therapy following surgery for impingement. Can you speak to long-term stress in conjunction with shoulder rotator cuff tear and arthritis? There's 2 ways to look at this question, and it centers around the word stress. The stress to oneself, dealing with this pain, or the stresses to the shoulder joint itself. So, people often ask me in rotator cuff surgery, that need rotator cuff surgery, well, what if I do nothing? Well, yes, the rotator cuff tear gets bigger. Well documented that small tears become medium-sized tears, and medium-sized tears become large tears, and large tears become massive tears. So the important thing to understand is the stress on the joint as these things start tearing. And here's my best, what I say is if all muscles are loaded like an elastic band, every muscle in your body has a load. And let's break it down to 4 cables, and these 4 cables have 10 pounds of weight on them. Well, when one of the cables go, how many pounds of weight do the 3 cables have? 10 pounds. And when 2 of the cables go, how many pounds of stress do these 2 strands have left? 10 pounds. And that's why small tears become big tears, and big tears become massive tears. What about the stress of oneself dealing with a rotator cuff tear and arthritis? It can be very stressful dealing with it, especially in a dominant arm, where you've lost the ability to do many functions that you're used to. You can't play tennis, you can't do an overhead serve, your golf swing has gone kaput, and this is very stressful. You can't even bring the groceries in anymore, you can't carry bags in from the car. So it is stressful dealing with a rotator cuff tear and arthritis in the shoulder joint. The having to adapt to not being able to do things is, I find, stressful for people. The good news is there are solutions to this. Is an MRI required for diagnosis many of the shoulder conditions covered tonight? Yes, in this modern world, an MRI is required, and I like to use it, surgical planning, to diagnose what is torn in the shoulder, how bad the tear is, how much retraction of the tear, and whether there's any atrophy of the muscles. That guides me into telling the patient what the best procedure for them is going to be. And unfortunately, the insurance company is driving this question now, because I'll have surgeries not approved by the insurance carrier because an MRI wasn't done. So insurance carriers are looking for 6 weeks of physical therapy, conservative management, and an MRI. What tests are required to diagnose the exact problem with the shoulder? There are tests we do in the office on physical exam that we can diagnose instability from rotator cuff tear from impingement. So there's simple tests we do in the office. But like I just said, usually we'll get an MRI to validate our opinion in the office. Would a shoulder problem cause neck pain? Quite the opposite. Neck pain causes shoulder pain. The neck has all the nerves going down into the shoulder and going down into the hand. So when I have patients come in that say, yeah, I got shoulder pain that goes all the way down to the tip of my fingers, I know that it's not the shoulder. I know it's the neck. And a very simple test I do, I put the arm out to the side, I take the head and I push it over like this, and I ask him, do you feel that tingling going down to to your fingertips now. And yes, and what have I done? I've stretched the brachial plexus right here, coming from the neck. So that's a very easy diagnosis, but the neck pain will cause shoulder pain, and it's good to separate out the two and get you in the right place to get that neck pain treated. My shoulder clicks when raised. I have full range of motion and take Advil daily. Can I take Advil for the rest of my life? I'm 66 years old. So clicking when you move your shoulder around, divided into two categories, painful or not painful. So if it's not painful, just continue doing the things you're doing. That's your bursa moving around inside the shoulder. So the bursa looks somewhat like the balloon inside the shoulder, but it's more mobile. So it'll move out here and move out the back and move down here. And when it moves, it'll click sometimes. The question of non-steroidal anti-inflammatories, Advil for the rest of my life. No. After the age of 60, taking non-steroidal anti-inflammatories should be done in the close conjunction with your primary care doctor or your orthopedic surgeon, because 20% of people over the age 60 will develop bleeding ulcers from non-steroidal anti-inflammatories. 4% of them will actually die from bleeding ulcers caused by non-steroidal anti-inflammatories. It's one of the most common reasons over the age of 60 people get admitted to the ICU. So you have to have this regulated. Anybody on long-term non-steroidal anti-inflammatories should be getting at least a complete blood count every 3 to 4 months and a chem analysis, a chem 7 every 3 to 4 months. So we like to watch that closely with the people. Do you ever use the Regenerative patch for initial tears? Is it covered by insurance? The use of the Regenerative patch for initial tears is sometimes used in very big tears. This is most likely in the traumatic situation, somebody thrown off a motorcycle bike, land on the shoulder. They have a massive tear of their rotator cuff, but we're getting to it within the first 4 weeks after the surgery. We repair it. We know there's a lot of stresses because it was a massive tear, so we'll use the Regenerative patch in that situation. Is it covered by insurance? Question I get every day. Is it covered by insurance? I don't know. There's 800 insurances out there. They all have their nuances. Even within the insurance company, there are nuances of what is covered and what isn't. And I always tell the patient, I write down Regenerative patch, I write down balloon arthroplasty, and I say, now go call your insurance company and ask them if this is covered. They're the only ones that can answer that question. Okay, the last question. Are impingement and AC joint issues typically bilateral? If you had one on one side, are you prone to having essentially one on the other side? No, because they're usually on the shoulder that you use the most. You usually get arthritis on, it's just like the knee. You don't get arthritis in both knees. You usually get arthritis in one knee first, and then the other one will slowly develop after. So you use your shoulders independent. They're non-weight bearing joints, and so we don't usually see impingement on one side. I would estimate that it's 10 to 15% of patients get bilateral impingement or bilateral AC joint. AC joint is the people bringing their arm across for a living, okay, and having to do a shuttle or that type of motion, they'll do it. Well, thank you again for your time. Please email any remaining questions to outreach@capecodhealth.org. Thank you very much.